Susheel, of course, Director of Structural Heart at Colombo University Hospital, one of the centers that does the maximum research on structural heart and transcatheter therapies.
So, yeah, I was going to do a step-by-step, but it's hard to do a step-by-step for all three devices, and maybe in future things we'll address things, and I think people have raised a lot of questions that I think the next sessions should be tips and tricks with different scenarios, reducing PPM, valve fracture, valve and ring, all of those things that people have raised. And I just thought, there's a lot of people on this call, and to sort of give my perspective on things to a successful procedure. And a lot of this stuff is come from experience, and a lot of it has come from stupid things that all of us have done, right? And it doesn't stop. I mean, as we've done thousands of cases, but we still push the limit sometimes. And when we look back and we've had a complication, you can always find a point in the decision tree where you could have done things differently. And the goal is to try and understand and learn from all of that, and we want to try and learn for people to learn from our mistakes. But I think everyone on this call has emphasized one of the key things to a successful procedure is pre-procedural planning. And pre-procedural planning starts with CT, ends with CT, but it doesn't include looking at coronary disease. It doesn't look at echo, LV function, all of those things that you have to think about. But also understanding the device and its limitations. And I think one of the challenges with that is there's multiple devices. If you're doing 20 cases a year, I think you need to become an expert in one device. If you're doing 100 cases a year, you can do several devices. And I think that's an important consideration. Don't do one case of one device and then do another case of another device. Procedural technique. And that, unfortunately, only comes with experience. You can learn a lot of these things. A lot of things that we learn from our coronary and interventional experience can be adapted. But in the end, sometimes it's just luck. We do things right. You may do things right the entire time, and you have a bad outcome, and you can't avoid it. But you can sort of help mitigate the risk of that. Understand the limits of transfemoral. We've seen from early experience that when people have a major vascular complication, especially in these patients that are in their 80s, they do poorly. And it sounds intuitive, and it makes sense. But if your sheath is bigger than the femoral artery, your risk of a complication increases. Now, in this initial analysis, early center experience and calcium in the femorals played a role as well. But be careful about pushing the limits. You just can't do it. Sometimes you can't fit. And as the devices have gotten smaller, the risk of complications have gotten less. And you should strive for major vascular complication rates of 2 to 3%. I think that's the standard at this point. And by major vascular, it doesn't mean they need surgical repair, but it means they're getting more than 2 units of blood, they're getting a covered stent, those type of things. And you're going to get those in patients where you have borderline access. Access like this, the risk of a vascular complication should be very low. Access like this, when you have calcium and at both the entry site and at the common iliac, even though the vessels may be large, your risk of complications go up. And what I would argue is whoever is doing the procedure needs to look at the CT. The CT cannot be just read by a radiologist. It has to be examined by the person doing the procedure. So then when you have difficulty advancing the sheath, you understand what you're dealing with and how much you can push. Be careful. The e-Sheath, everyone, the Evolute is a true 14 French ID. With Edwards and my valve, there's the sheath expansion. So the sheath does temporarily expand and can get as much as 8 millimeters for a 29 millimeter valve. And I think you have to be careful and understand that because if you have circumferential calcium and a 6 millimeter diameter, you're going to have a hard time expanding and you may injure the vessel. And in these sheaths, you got to look at the entire anatomy. This is a case of ours. The sheath ended on a bend in the aorta. We didn't have that stiff a wire. It was an Amplatz extra stiff. And you see that the device is coming out of the side of the sheath. And as it does that, it's creating more injury into the aortic wall. In this case, we did the case, and then valve went fine. Patient became hypotensive. And you see here, we have an abdominal aortic perforation. And that we had to put a covered stent, and the patient survived, but he ended up getting 8 units of blood for a large abdominal aortic bleed. And so that was from the sheath entering the abdominal aorta. And understanding the entire vascular tree is key. This is a patient with significant tortuosity in the abdominal aorta. This is another example where the BAV sheath kinked. So in these cases, putting a second stiff wire from the other side, you see how the aorta with one stiff wire still has that bend. As you put a second stiff wire, that bend goes away. Not fully, but it becomes easier. So when I'm putting the sheath up, I keep, in the pigtail catheter, I keep a Lunderquist on the contralateral side. So it helps straighten the abdominal aorta. I put the sheath up, and until I get my valve catheter into the ascending aorta, I don't take the Lunderquist out. At that point, I'll take the Lunderquist out and hook up the pigtail for injection. But the second wire helps straighten that out. And you see in this case where this is where that BAV sheath had kinked, you see how much straighter it is. And because once you take the dilator out, these sheaths can kink, and that can cause you a problem. So in these scenarios, I always keep a stiff wire in the pigtail side to help straighten the abdominal aorta when you have a lot of tortuosity. It can make your life a lot easier. Calcified, tortuous. These are the key things: calcification, tortuosity, and vessel size. A vessel size greater than 8 is fine. But if it's calcified and rigid like a lead pipe here, it doesn't mean it's benign. And this is what can happen. These are large vessels. That video, unfortunately, doesn't play great, but what you see here is the nose cone of the core valve is separating. So if you keep pushing, you're not pushing in this direction. You're pushing up, and you're going to perforate the iliac. There are things that you can do. You can overcapture the core valve, and that will allow you to potentially make it stiffer. But ideally, I just put a stiff wire, or I put a sheath. If your vessel's large enough, you can put a sheath there, and you can put an 18-French sheath and put your core valve through that sheath, and I think that would make things go a lot easier. But you have to understand, and you see this, you just can't keep pushing. You have to have strategies, and ideally, our preferred strategy is putting a sheath or a stiff wire. So let me move on here. And then one of the key things is appropriately sizing the valve. And this all comes down to CT and understanding what the CT is showing you. The annulus is a complex three-dimensional structure. And you can't really just look at one measurement. And you're creating this virtual annulus. And it's often very elliptical. And there's a lot of challenges. And, we should do one webinar on how to measure CT and what you're looking for. But there are a lot of ways to look at it. We look at area or perimeter for core valve, area for balloon expandable, but understanding the anatomy, where are the coronaries, what is the diameter of the STJ, what is the calcium at the STJ, all of these things are what are going to predict risk and poor outcome. But also understand that there's variability. When people do a cardiac CTA, the radiologists are used to doing prospective gating and diastolic imaging, and because they want to save radiation. So they only give you the diastolic phase. There's a lot of variability between systolic and diastolic phase. And one study from the Vancouver group showed it can be as much as 10% variability. And that can take you from one size to the other. It may not, but you should understand the variability from systolic and diastolic measurements. And then the key thing is the CT is only helpful if you know how to analyze it, or whoever's analyzing it is doing appropriately. In this view, you're still seeing valve leaflet. So you're not going to measure the annulus correctly. So a poorly measured CT is dangerous, and I think you have to be careful of that. A poorly acquired CT is dangerous. These are stair-step artifacts. If you're using a 16 slice, especially, or even a 64 slice, you're going to get a lot of artifact because they got to stitch together different volume sets. This is one volume set. This is another volume set. If you have a 320 or 256 scanner, you can capture the entire annulus in one heartbeat. So understand the scanner you have and the type of imaging. You see artifact like this, be cautious. Don't just take the measurement on face. If you have a poor CT with motion artifact, step artifact, and other things, repeat the CT or use TEE for guidance. And then don't push it. Sometimes the anatomies are not good, right? These are patients with a lot of LVOT calcium, effaced sinuses. When you push the limit, you get things like this. This is where we created a hematoma in the aortic root. Because the sinus was effaced, there was bulky calcium, we overinflated, and the calcium pushed into the root. So ideal anatomy is great, but these are not ideal anatomy. And you have to understand that it's not going to work in all of these cases. And you have to be willing. In a low-risk person, anatomy like this, you would maybe say surgery. In a high-risk person, you can do the case, but you have to do it with caution. I think that's important to keep in mind. And this is an example of a patient we did with a lot of calcium. And when you have a lot of calcium, the risk of annular rupture is increased by both calcium and oversizing. So if you have a lot of calcium and you're oversized a lot, those are the two highest risk factors for annular rupture. And those are catastrophic complications. So this is a patient we had with a lot of calcium, as I showed you. we deployed an Evolute. And what you see here is the Evolute is not expanding. That LVOT is keeping it from expanding. This is early in our experience, but it didn't expand. We did multiple post-dilatations, and we had this severe leak right there. You see this gap right here. This is on transthoracic imaging. We just couldn't expand because of that bar of calcium in the LVOT. You have to understand that going in. In this case, we ballooned, nothing was working. It was a fair amount of leak. So we ended up at the same setting, crossing it with a wire and putting an Amplatzer plug. This is the an 8 millimeter AVP2 plug being deployed. And you see here we're alongside the core valve frame where that gap is. And this is where that calcium in the LVOT is. So the idea is to try and seal in that area and reduce the amount of leak. And you see the plug is deployed there. Let's see this moves forward here. Oh, there it is. So the plug is deployed, and we do a final aortogram. And the leak is still there, but it's significantly less. It's very mild, where it was severe before. And so this was managed because we understood the anatomy before that it wasn't going to get better. And on TTE, you see, again, a very mild leak at that point. Coaxial views, understanding the imaging. We're trying to deploy a valve in three-dimensional space with two-dimensional imaging. You need to get lined up. You can use your CT to get your coaxial view. Make sure you have it, whether it's core valve or sapien. We'll talk about in another session about the cusp overlap for core valve and everything else. But these coaxial views are important, and understand your device. Balloon expandable, as Vinny said, has differential expansion. You see here the top essentially stays where it is. So we really position our valve looking at the top of the valve. In most of these cases, I want the valve as high as possible, so I put it at the top of near the STJ. And when you're talking about coaxial views, you need to understand about parallax. And you're looking at, this is a coaxial view, here's your annular plane. Ideally, your device, you see the ring on the core valve is in the same plane, and your valve deploys evenly across the annulus. But a lot of times, you're not coaxial with both. You're offline with your device. There is a view that's going to be perpendicular to be both. But you can see here how when the valve is coming into the annulus, it's very non-coaxial. And when you deploy this way, you can be high on one side and low on the other, as you see here. This represents the bottom of the core valve frame, and you may low on one side and high on the other. And that's okay. You just have to understand it. And it's going to be more of an issue with horizontal aortas potentially. And you see here aortogram in a non-coplanar view, an aortogram without parallax. And what I want to do here is illustrate is when you see the annulus, this part here, when you're coaxial to the annulus, represents the lowest part of the core valve. Here in this view, we're perpendicular to the core valve frame. The right cusp is higher, but this represents your highest point on the core valve. And I think this tricks can help you to understand how you're differential. Here on the non-coronary, we're 1 or 2. On the right coronary, we're probably around 6 or 8. So that will help you. In the interest of time, I'm going to go through the wire. We all know how to curve the wire. Again, coronary disease is a separate topic, and we'll talk about it, but I just want to introduce it. Don't ignore it, especially in younger patients having angina. Understand the relevance of coronary disease. You may want to fix it first, especially if you're doing a core valve. And the coronary disease is relevant to the safety of the procedure if you're talking about patients with depressed LV function. And what I mean by that, if you have a patient with an EF of 20% whose filling pressures are high and their LV EDP is 20, if they have coronary disease, if you do rapid pacing or the patient gets hypotensive due to AI, the EDP goes up quickly, coronary perfusion pressure goes down, and there's an ischemic spiral that occurs. So in a patient with normal LV function and normal hemodynamics and critical AS, coronary disease may not play a role. But in patients with depressed LV function or high fill-in pressures, it may. So you have to think of all these things, and this will be a separate topic, but I want to just introduce that. And part of the things I want to raise is we use TE a lot in high-risk cases. It's a lot of LVOT calcium, effaced sinuses, high risk of coronary obstruction. Those type of cases we do with TE. The rest of the cases we do awake. So we feel comfortable doing a case, like we've done zero contrast cases, patients with severe allergies, everything done on ultrasound and TE. But we do that because there's a learning curve to TE, and our imagers are very comfortable with doing TE guided TAVRs. But because TE gives you an assessment of all risk, and it also allows you to diagnose quickly when you have hypotension and emergencies. But there is a learning curve. So try and learn, involve your imagers and learn from TEE and involve that in all these scenarios. And, this is an example. And see how on TEE, we see in a balloon expandable that the aorta is being threatened as we expand. It's pushing into the root. So we may stop inflating or we may inflate slowly when we see this. And the TEE helps guide us. And we don't overinflate, because if we overinflate, we're going to create a hematoma or an injury there. And again, once you do, every patient should have a completion angiogram. You will see things there when you do that. And this is an example. Patient wasn't bleeding externally, but there was a dissection. We already had a wire across, simply did a balloon inflation, and the final result looked great. So you need to do a completion angiogram. But experience is what improves outcomes. That's been shown from the TVT. And so you just got to learn from experience, learn from your colleagues, and learn from courses like this. Thank you very much.
Susheel, you blitzed past that. That was an excellent talk. Susheel, I have just one question for you. I have a question from Dr. Atul Mathur. IVL assisted vascular access. Can somebody just pin Dr. Mathur on the screen and unmute him so that he can ask Susheel the question, please? Hi, Dr. Mathur.
I think he's still muted, unfortunately.
Can somebody unmute him?
Yes.
There you go, Dr. Mathur.
Yeah, hi, excellent presentations. There's so much packed and short presentations is really exciting. So I thought maybe if you have time, because there is a lot of talk about shockwave therapy in peripheral vascular disease. And number of times, like you mentioned, there is an access problem when you've got calcium all around your iliacs and the femorals. So have you had any experience with using shockwave to find your way up in vessels which are badly diseased? This is to any one of our experts.
Yes, absolutely. We've probably done a dozen cases or so with shockwave assisted. I think shockwave is a great tool, and especially when you have a focal calcified area. I think it's ideal. And we will look at that, and if we think we can balloon it or shockwave and get the sheath up, that will be our preferred strategy. I think you have to understand it won't work in all scenarios. If it's diffusely calcified along a long length and small, then I don't push it. But if it's especially in the common iliac, I think shockwave is a great therapy.
So let's just go to Ganesh's talk now.
Sai, I have a comment before we go on to Dr. Ganesh's. That was, Susheel always, gives wonderful presentations based on, of course, his huge experience. And I'm so glad.
Can we pin Dr. Chandra, please? Can we pin Dr. Chandra?
So I'm also glad that Dr. Grube is here, and glad to see him, and of course my other colleagues. So the thing is that the case Dr. Susheel showed about that unexpansion of the self-expanding stent and that heavy chunky calcium on one side, we have seen in few patients now, and really it is a challenge that whatever you do, the PVL remains. And we also tried to do a few such tricks. First, of course, was the paravalvular leak closure, doing the device itself. And then, we had some, the device, actually the sheath could not cross the stent struts. That was a problem in one of the cases. However, in some cases, we were able to cross it, put the device inside, still the leak was there. Then we put the second stent in stent, still it was not working. So we were so frustrated that we put the third stent. And in fact, we showed this case in the last TVT. So that is, sometimes it is very, very frustrating, I can tell you.
And I think you raised the point. Sometimes there's limitations of the anatomy, and you have to respect that and understand that. And I think especially in a low risk person, there's some bad anatomies, and that patient should just have surgery.
So thank you so much, Dr. Chandra. Admin, can you pin Dr. Srinivasa Kumar? And I think Dr. Grube should take this question, though Susheel will be itching to say hello. He said, I'm going to let him ask the question himself. And it was basically why we had Dr. Grube speak. So it'll be really nice if you can ask the question. And if Dr. Grube is around, he can pick this up. Go ahead, Srini. One sec, Srini. Srini, you have to unmute yourself. I'm just going to do it. Hang on. Admin, can you unmute Dr. Srini? Yeah, go ahead.
Yeah, I think I'm audible now.
Yep, perfect.
Hello. Yes, thanks for it. I didn't want to ask it myself anyway. As usual, you surprise people. And excellent lectures. One request from all the webinar participants, I would say, is just give us circulate these recordings of all these again to everybody so that people can listen. Susheel's Power Pack talks, the information is so much in so much of these talks. I think we should listen again one more time. Susheel, after so much of experience also, he keeps on thinking about what is good for the patients and do what is best for it. That's the approach I think we are learning from him. Thanks, Susheel. And one thing, after seeing all these experts talk, what I was feeling, what I wrote to Sai was, it's high time now we should develop a CT or echo score. I think one of person, Rebecca Han or somebody was working on it, where we score is ideal, we do a TAVR. If patient is not suitable for TAVR, then maybe those patients go for surgical aortic valve replacement, obviously in some patients pre-specified age groups. So I think, are we there to develop that score to assess suitability for TAVR? That's what I wanted to
Vinny,
ask your opinion.
When we are talking about surgery and cardiology, Vinny, Dr. Grube, anybody?
Let Eberhard speak, but I think it's slightly different than the syntax score, because I think we are also going to take into consideration the risk profile, like age and life expectancy of the patient. So I think we see calcium score is important once you decide, but I'll let Eberhard actually talk about it.
I think, Vinny, it's important because you are, I have, basically we have the same opinions about these things. And I think, with your surgical expertise and at the same time interventional expertise, you can best weigh into what is best for the patient. To be very honest, I don't like to push the limits on TAVR. I understand the topic of my talk was such that obviously everyone would be considered, but that is due to the fact that if possible, I would prefer TAVR. Now, if possible, and that's the question now, what are the remaining issues? And I think what is important is that we don't force ourselves into a situation where we say surgery is only bad for the real bad ones. I agree that if you have a good candidate for TAVR, that should be done. In this case, TAVR should be done. But on the other hand, there's so many variations, individual variations that have to be evaluated with your surgical colleagues. To be honest, if you go to an excellent surgeon, the patient will have the same, if not better outcome in a complex structure. So I don't want to push the limits to say, surgery is being marginalized. I think at the end of the day, we're treating a patient. We don't look for our own values as interventionists and surgeons. I think that's why we have the heart team. And there are many things that I can think of, particularly listening to these great presentations, where I would say, don't push the limits. Talk to the surgeon, and if he puts in a valve with excellent results, avoiding some of the bad complications that we have in doing the TAVR procedure, he should go ahead with surgery. I don't say this lightly, but on the other hand, we have to still treat a patient and not look to the to our own, preference as to surgical or TAVR. I think at the end, the surrounding, surrounding anatomies and risk factors play a very, very fundamental role.
I think, Sai, this is very important. I think I may be the only surgeon on this thing, so I can say something is, I think a good TAVI is better than bad surgery, and bad TAVI is of course worse than good surgery. So I think the question is, when we have a choice, we have to use it properly. And I always give an example. Growing up in India, I used to go to the college canteen and there was only tea or coffee. There was only 2 options. Now we go to a coffee shop, there are 10 options and the head starts spinning. So I think it's very important how we decide. And Susheel's case of a evolutar, which was not expanding fully, and we use PV leg, plugs. The only reason was patient was not at all suitable for surgery. So then what we decided is it worth compromising on some things and tackle them in a different way so as to give patient the best benefit. And I think that's the critical thing about heart team. And Ganesh has experienced it. I'm sure St. Thomas has also, and Eberhard and Susheel, is that if your surgeons are engaged fully, they will actually refer and agree for more patients to have TAVI than people who are on the fringes and feel very offended by, you know, the whole technology taking over. So maybe the views are changing for sure.